If I could. Perfect. That's exactly what I was trying to do. How's everyone doing today? It's kind of a gloomy Friday out here in Farmington, but yeah, it's looking a little bit more like holiday time. Okay. Gonna go ahead and share screen. Oh, thumbs up from Brenda. Very cool. All right. Gonna get our slides pulled up here and we'll get started. So, welcome to our Health Council Talks today. If you're not familiar with what Health Council Talks are, essentially it's a meeting space for us to come together as health councils and partners to learn about resources, learn about different programs and services in our state, and essentially trying to bring more of those services to your community. So today we'll be hearing from the New Mexico Department of Health. But before we go ahead and move into that, again, I hope you're all having a wonderful Friday. I'm getting ready for the weekend and the holidays next week. I'm going to go ahead and pass right now to Martha to lead us with our land acknowledgement.
Good morning, everyone. I will now read our land acknowledgement. The New Mexico Alliance of Health Councils gives a sincere gratitude for the opportunity to live and work here on ancestral and unceded lands that have been cared for by our state's original peoples of the Apache Nations, Pueblos, and the Navajo Nation. We honor and respect the indigenous cultures, traditions, languages, and the rich contributions that continue to shape New Mexico. Together, we acknowledge the history and impact of genocide, dispossession, colonization, and ongoing systemic inequities on Indigenous communities. As a collective, we commit ourselves to working toward justice and reconciliation, dismantling inequitable systems, standing in solidarity with and respecting relationships with Indigenous peoples. The Alliance affirms Indigenous sovereignty, self-determination, and self-governance of New Mexico's tribes, pueblos, and nations. In offering this land acknowledgement, we encourage you all to reflect on your own relationship to the traditional lands and take concrete actions to dismantle systems of oppression where Indigenous peoples are empowered and celebrated.
Thank you so much, Martha, for opening us with our land acknowledgement. Okay, so before we hand off to Phil here at the Department of Health for his presentation, I'm just going to share a few quick updates that Sam had for us this week. Again, it's legislative time. We are year-round doing year-round advocacy. So we are looking for stories with your representative and senator. Um, the interim sessions are happening now, but sessions will start next year. But if you have any stories you'd like to share, please contact myself or Sam. We'd love to kind of gather those and start utilizing those, for social media and marketing, and getting everyone excited about the session. Second here is there will be a tribal consultation hosted on December 2nd for tribal leaders and designees. And this is very specific to Senate Bill 3, the Behavioral Health Reform and Investment Act. Um, Again, this is just providing a space for government to government conversation, specifically to SB 3, around concerns, priorities, and then just ensuring tribal perspectives are also honored. And so this will be happening in person. Actually, I think it is a hybrid meeting. So in person in Albuquerque, but there will be a virtual link coming for others who cannot join. So just a little reminder about that. And updates. So Sam's got a lot here for us. We are still doing outreach for the membership agreement. And the reason we're doing outreach right now is we are preparing for a return on investment study that we're doing with UNM. The last one we did was in 2015, and so that was every dollar invested into health councils, the investment, or sorry, essentially like the yield, right? The ROI was $2. So it's been 10 years, and what we want to do here at the Alliance is do another ROI with UNM. Only using aggregate data that we've been presenting to legislators from FY25 impact data. So part of the agreement includes a consent for that. And we're aiming to kind of get all of the agreements back in the consent by the end of November, early December. But if you have questions, please reach out to us. The second big thing I'll hit on this here is we are continuing the statewide meeting and public health day planning meetings. Um, if you already don't know, good news, we are having a 2-day statewide meeting. So the Alliance has secured enough sponsorship funding for that. So that is on January 26th and January 27th. And then the Public Health Day will be on the 28th. So we're going to be having a 3-day convening um, in January. So I hope you're all excited about that and more to come on that information. Okay, if you have questions, I will be in chat later if you want to chat me about any of the updates I mentioned. But I'll hand off to Phil. He's with the New Mexico Department of Health. He is a technical advisor for the adulterant checking program. And so he has been providing harm reduction based activities and services for almost 40 years, beginning with an underground syringe and naloxone distribution in response to the HIV crisis in the 1980s and 90s. He also has volunteered and has been employed as a street outreach worker and was the statewide harm reduction program manager for DOH from 2002 to 2006 and spent 10 years as the harm reduction program director for the Mountain Center in northern New Mexico before joining Vital Strategies. His independent work has included harm reduction and research for methamphetamine and stimulant use, safe access to medical cannabis, um, the use of ayahuasca. Am I saying that right, Phil? Ayahuasca. And ibogaine for the treatment of STD and worked as a consultant, trainer, and administrator for the federal STR, PDO, SOR, FR, CARA, and HRSA overdose and OUD grants for New Mexico, Santa Fe, and Rio Arriba. He is the consumer health advocate appointee to the New Mexico governor's Overdose Prevention and Pain Management Advisory Council and has served as the network coordinator for Rio Rural County's Rural Overdose Prevention Grant and an overdose trainer and consultant with DOH's ODT2A team. All right. Thanks, Phil. I love your bio because it a refresher on some of the terms here and a lot of acronyms, which we love in Health Council world. So I will pause and hand off to you. I'm going to stop share if you'd like to share your slides. Oh, I think you're on mute still, my friend.
Sorry. Uh, we get noisy in the background here sometime because uh, my office is actually in the hallway.
Hmm,
Oh, that,
no worries.
that works. And bring that up. There we go. And slideshow from beginning. All right. Hi. Yes, I was thinking as you were talking earlier, and I was reading the slide of Sam's information, that I have a whole bunch of new acronyms for everybody today. So everything we do seems to be come with a whole lot of that. Probably may say some things that are confusing to people, and I can't really see the thing when I'm in presenter mode. But by all means, uh, if it's a urgent question, speak up. Otherwise, put it in the chat, and we will be able to talk about that. I'll go back and answer those afterwards. So again, my name is Philip Feudy. My official title is Technical Advisor for the Adulterant Checking Program, which is I'm employed by an organization called Vital Strategies, which is a global public health organization that does just all kinds of amazing work around the globe. Um, fighting the tobacco industry in other countries, urban health, nutrition, clean air and water, just alcohol stuff, just an amazing amount of work. Our only domestic program is the overdose prevention program. And I know there's, I think most, if not all, of our uh, tribal communities in New Mexico uh, may have received funding from them this year uh, for to help build out access to uh, MOUD medications for opioid use disorder and other harm reduction initiatives. The They pay my salary, but I'm actually embedded at the Department of Health in within the harm reduction section. Um, and my job is to implement the adulterin checking program or the drug checking program, and I will explain what that is and how it works. A few acknowledgments, again, vital strategies, and once again, like to thank the Department of Health for uh, bringing me on and turning me loose and letting me do what I do best, which is seems to be building out programs. Um, the Remedy Alliance is a national harm reduction organization that we've partnered with, who is providing our training and technical assistance with the program. University of North Carolina is our lab partner, with whom we're sending samples for confirmatory testing. CFSRE, another partner, and some of their materials appear in here. Uh, BCCSU, British Columbia, has made this type of programming possible, and I'll talk about that in a minute. And University of Victoria is another direct partner of ours that's helping us build this out. So, um, there's a just a little bit about me, just as a way of saying that I've been at this for a really long time. It was an accidental career. I had no idea that my whole entire life was going to be about drugs when I graduated high school. But it's been really just some amazing opportunities and a chance to really provide back to our communities and community members. The pictures on the right are me using one of the portable mass spectrometers that I will talk some more about here in a minute. A few years ago, I was monitoring a bill that was going through the legislature, and I was there to speak on it. And it was a, a harm reduction uh, initiative, I think Overdose Prevention Center or something that someone the Drug Policy Alliance had submitted. And during the conversation in one of the committees, one of our senators asked, he said, I don't know what all it is you guys are talking about, but I know when my kids go out to play where we live that there's this arroyo and there's always needles in it. And whoever I call tells me it's not their problem and tells me to call somebody else. I call the city, they tell me to call the county tells me to call the state tells me to, and and someone said, well, what you need to do is, do you know if you have a harm reduction program near you? And he was like, what is that? And they said, well, the state does, syringe exchange and other services that are meant as intervention for people who are using substances. And he paused and he said, you mean to tell me that the state of New Mexico has a program that gives needles to addicts? And my first thought was that I'm getting old. But my takeaway from that is that, we're one of the leaders in this work nationally, and we've been doing it for a very long time. So long, in fact, that there's people around in within the Department of Health, within our government, within other entities that have no idea that we even do these things. So I like to not assume that everybody knows, and I'm going to go over a little bit of history to set some context. Um, when you hear the words harm and reduction together in a sentence, it is usually associated with syringe exchange and now with distribution of safe using supplies. Um, we've been doing this for a very long time. It is an actual evidence-based intervention. In fact, it's one of the most effective ones with substance use, and it's entirely based on the stages of change model that so much of us are familiar with. The pre-contemplation, contemplation, practice, taking the action, maintenance, relapse. And when most people, and we think of it as treatment, right? Not so much prevention strategy. When we say the word treatment and most people think of that, they're thinking of um, uh, detox and inpatient and outpatient, but that really only exists in that like three parts of that stages of change model. And what we're doing in harm reduction is working with the other three quarters of that. So people in pre-contemplation and contemplation. And it's been shown uh, without a doubt that more people who are engaged in substance use, chaotic substance use, which tend to be the most of the people that we work with, have been able to access treatment and other necessary services through their participation with these types of programs. So in 1997, well, in 1994 to 96, the Department of Health undertook the study on the right, and we were seeing what they called the second wave of HIV happening in the 90s. And in the urban areas, there was tremendous amounts of people acquiring HIV through injection drug use. And we didn't really know what was going on here in New Mexico. We knew that we had issues with overdose in some places by that point. Rio Arriba County, uh, and a few other places, but we didn't really know what was happening with HIV. So we went out and conducted this study, and based on that study, we're able to get a bill through the legislature, and Governor Johnson signed it, um, which set the stage and allowed us to start doing these programs. What this study found after screening at 1,003 individuals who were using substances, injecting substances at the time, all around the state, we only found one person that was previously undiagnosed with HIV. But at the time, we found that 61% were also hepatitis B positive. We found this 82% hepatitis C positivity. Um, uh, but it also came to light later, in the 2000s, as more research was done, that uh, about 83% of everyone who initiates injection practices has been exposed to hepatitis C within 6 months. But based on this data, we saw an opportunity, a very to prevent HIV from ever taking hold in New Mexico the way that it had in other places. And uh, I would say that we've been very successful. New Mexico still has a very, very low uh, incidence of HIV, new HIV infections among people who inject substances. You can't really take epidata and say because we did this, we don't have that, but it appears to have played out that way. Um, and we've brought the hepatitis A and B rates back into normal range as well. So, um, the law is very simple. Originally, it just said that we will establish and administer a program for syringe exchange. We updated that in 2022 because of shifts in the drug supply and in how people use substances. Um, we wanted to remove the needle-specific language to give us more flexibility in addressing the way that people are using substances. And but Part two is still the same, that we are collecting data, and that data is informing our not only bloodborne diseases, but also overdose. Um, some additions to that: in 2001, we were the first state to pass legislation to make naloxone available. '07, we were the first state to implement overdose Good Samaritan laws um, for overdose. 2015, we were a little behind everybody else in doing naloxone standing orders, which finally made it possible for non-prescribing individuals to distribute naloxone by following certain rules set out by whoever either within their organization, a physician in their organization, or the state has issued some as well to cover distribution. 2016, we got rid of some of the original regulations, which weren't didn't really work out for the largely rural and frontier communities in New Mexico. And as pertains to why I'm here today, we did House Bill 52 in 2022. And that was about being able to make the fentanyl test strips available to people. But we also included that down there, that Part C, supplies or devices used for testing controlled substances for adulterants. And that's where I come in. So I don't need to really probably tell anybody about this other than to point out that New Mexico was one of the last places where fentanyl showed up and replaced heroin, and that happened in 2019. And you can see on this from this form that we fit right into that area where nationally the overdose deaths really began to go straight up. That happened on the heels of a drug trafficking organization that connected Juarez all the way to Espanola. And I was working up there at the time with the Mountain Center when this took place. And that was pretty much the end of heroin in Rio Arriba and pretty much the rest of the state. Not the end of it, but what came in to replace it was fentanyl. And we first identified it in October of 2019, and it then proceeded to uh, drive out heroin for a very long time. There's heroin back again, but there have been several studies that have shown that drug interdiction efforts, when there are large scale busts that happen like this, or even small ones, that it's associated with an increase in overdose death because of the disruptions in the supply. Um, New drugs coming in, and it's different than what people were doing, and there's a corresponding uh, unfortunate corresponding relationship between those two. So, so when we talk about drug checking, right, it's really an intervention that, in the absence of having a safe and regulated supply, and what I mean by that is like alcohol or nicotine products, caffeine products, and things. Those are uh, safe and regulated supplies of potentially dangerous substances. It doesn't totally remove the danger from them, but you're not going into a bar or Starbucks and ordering a drink and risking going blind or dying uh, from taking a drink of those substances. Over-the-counter medications and prescription substances are also safe and regulated. Illicit substances are not, and so the next best thing is for us to be able to take good, accurate looks at substances that people are planning on using or have used and had there were unexpected result, you know, unexpected things happen to them, and now we are able to take a look at that through this program, and we're getting the first real good uh, picture of what's happening out there. One on the left here is a whiteboard that the Mountain Center in Espanola put up, has up where people are coming in to access their other services. Um, and the one on the right is from the program in Albuquerque from their newsletter. I have some updated images that I will replace these with soon. Uh, we also have a program in Las Cruces, which is where I am and what I do down here, and we have another one in Roswell. So this is the uh, participant guide that we came up with for the program, both to help our participants, but also folks accessing our services understand what we're doing. We're able to check most things, and we're it's sort of just like we do with HIV or hepatitis C rapid testing. Um, at the point of care, we're able to make a reasonable determination of what might be present in somebody's substances, and then we send a sample to the lab, um, and then they can see all the rest of the things that we can't. When we're talking about sample collection, we're not talking about huge amounts of drugs whatsoever. Most of the time, we can do it with just waste products. So, like a baggie that they've already taken everything out of that has some residual dust in it, or little bits of a pill. Um, and then with liquids and things, there's other ways to do that. I just had a client come in on Monday who purchased some testosterone online, and I was able to determine that there was in fact testosterone in their sample, in the sample that we looked at. So it's another aspect that is becoming more important of these programs as access to those things have been becoming more difficult, and uh, the kind of service that we can provide beyond just our usual target audience with this. What we're looking for is, besides the substance itself, are different things that we call cutting agents. Those are usually non, uh, what does it say? Non-active, pharmacologically active ingredients that are used. It's not so much to add bulk for financial reasons, but more to make synthetic drugs that are very minute amounts. People have always relied on their senses to kind of determine, historically, to determine what if their drugs were any good or not. And that was smell and taste and solubility and all those kinds of things. But as we've moved into synthetic drugs, which are extremely potent in near microscopic amounts, the senses have become really aren't really a way to for people to determine what's happening. And so to take something like fentanyl, which is very potent in small amounts, and to divide that into doses accurately into doses that shouldn't hurt people. Um, that's done by mixing it or binding it with things like mannitol or inositol, which adds the bulk that allows people to divide it up more accurately. The other thing we're looking for is adulterants, which pharmacologically active substances. Sometimes that could be fentanyl and heroin or something to that effect. Uh, Acetaminophen is very common. Caffeine, we see. I just tested a sample 2 weeks ago that had some, I don't even know how to say that, guaifenesin in it. We've had dextromethorphan. We're starting to see, well, there's been a lot of these local anesthetics in the fentanyl supply, the lidocaine and procaine. We're got xylazine happening pretty more than 50% of the time in fentanyl samples, and we're starting to see medetomidine now too. I'll talk about that near the end. Um, the technologies that we're using, so at the point of care, we're using test strips, fentanyl, xylazine, benzodiazepine, nitazene, and now medetomidine test strips, and our portable mass spectrometers, which are FTIRs, or Fourier transform infrared. It basically shoots a little laser of infrared radiation through the sample, and then it measures the different amounts of light that were absorbed by the molecules. Our laboratory partner uses a much bigger and more accurate gas chromatography mass spec, which is able to really give us a good qualitative analysis of all the things that we can't necessarily see with the FTIRs. So we use the FTIRs have what we call a limit of detection, and it's generally about 5%, meaning that in order for the FTIR to be able to see something, it needs to be 5% or more of the sample that it looks at. And fentanyl and xylazine, benzodiazepines, nitazenes, medetomidine, LSD, oxycodone, and many other things are very potent in the the licit or illicit substances, uh, pills and things that they're in. And we can't see those usually, but we can see them with the test strips because those are measure very small amounts down to the parts per million. So we'll look at it with both of those technologies and are able to make a general determination. Back in 2021, this was the first pill that we actually counterfeit pill that we had analyzed in the state. Looking at it, this was in Espanola at Espanola Presbyterian Hospital. An individual was brought in by EMS who had experienced an overdose, and Dr. Ketchum there and the team was unfortunately not able to save that person. But that person's spouse brought in a couple of these pills and said, these are what this person has been using. And we sent it to the UCSF DEA toxicology lab in California, and these were the results of that. And it this turns out to be that these counterfeit pills are a pretty specific recipe. And although these ingredients here change, you know, they're not always this set of ingredients. The the amounts that are there more or less followed this pattern, and so almost half of the pill was acetaminophen, which is pretty normal. What you don't see here is that the other just over 50% of the pill was mannitol. Um, they used an LCMS here, time of LC quadruple time of flight mass spectrometer on this, and that one can do the quantification. We normally don't do that, but it's also not. It's kind of subjective. It doesn't mean something to necessarily have different percentages of to know what the percentage of say fentanyl was, because if you look at this down here, about less than 1% of that pill was fentanyl, but the doctor's comment up here that it equals 840 micrograms of fentanyl, um, which is really anywhere from 4 to 8 times a standard pain dose in the hospital, right? So still a very potent uh, thing, even though someone might, if we were to tell them, oh yeah, 80%, your less than 1% of your pill is actually fentanyl, people would get all grumpy about it. But um, again, those things are kind of subjective. And there's a lot of really, what we're learning is that there's a lot of very misleading information out there, including when they say, 2 milligrams of fentanyl is a potentially lethal dose. There are so many factors that uh, comprise the phenomenon of overdose. The person that's using their health, their well-being, their circumstances, previous overdoses, and et cetera, that go into that, and then their tolerance, and then other things. And so uh, we don't we don't focus a lot on that part of it, but this was our first really good picture of what that looks like. So uh, there I am again on the right, and the one on the left is from Albuquerque. And the way that this machine behind me works is after it takes the scan, um, it produces a spectra, which is this one of the red squiggly line here. And that each one of these peaks represents a different signal in the scan. And the same substance appears in the same place on those peaks every time. And so once we have that spectra, we run it. It compares it to um, uh, the libraries of pharmaceutical and street substances that we have. What we're trying to do, if you look on the bottom left here, is look for uh, peaks that are not accounted for by the library scans, and then work to identify uh, those peaks. And so last year, these peaks were appearing midsummer through the present, and they turned out to be a new chemical that entered the supply last year called BTMPS. And our technician at the Mountain Center last year was the first one in the country to actually identify it um, in the counterfeit fentanyl pills versus fentanyl powder, where it had been turning up in other places. So uh, I can talk more about BTMPS. And that person was Kelly. And this is a little case study just to show what the process looks like. So she had a person bring in a sample that was sold to them as fentanyl, and its appearance uh, was weird. It was black tar with green and blue flecks. The picture on the left is what it looked like when we added it to the chemical that neutralizes it before we send it to the lab. So a lot of green in there. The person indicated that they had used it already and it was stronger than what they were used to. When Kelly did the test strips on it, it was positive on a fentanyl test strip, positive on a xylazine test strip. And when she looked at it on the FTIR, it came up as acetaminophen and mannitol, which is normal. And then one version of fentanyl or something that came up on the screen. So um, now lidocaine, that's also been present in a lot of samples since last year. is also known to cause false positives on xylazine test strips. And so wasn't sure. She was not unable to determine if there was really xylazine in there or if it was lidocaine. So, so this is what we have when we're talking to the person, uh, and then when she got the lab results, when the lab results became available, this is what the sample actually looked like. So major substances means that they're in there in a significant amount, uh, enough to maybe be have an effect of their own or be potentially problematic for people. So it was fentanyl. Um, it was lidocaine and not xylazine. Methamphetamine was a surprise. Didn't see that on the spectra. It turns out that that's very common, and I'll talk about that in a little bit. Um, Acetaminophen, and there was also heroin. These trace items on the bottom here, 4-ANPP, is a precursor chemical. It's used to make fentanyl. And then 6-monoacetylmorphine and acetylcodeine are both products of making heroin, turning morphine into. They're often there. So yeah, so this is the kind of stuff that we're able to look at now. I think before I go into this, providing the service here myself, and for having done this kind of work for so long, over 30 years, almost 40 years, um, doing HIV testing and hepatitis screening and all the other things that we do. Sitting here and going through the process with an individual has been one of the most powerful relationship building experiences I've had in all the years of doing this work. Explaining to them why it is we can do this work now, uh, turning on the machine and going through each of the steps with them, and while they're sharing information about where, about the where how they bought it or why they were suspicious of it, the different circumstances in their life. And so even though we didn't necessarily see all the things here, it's in the process of do to looking at these things that the intervention really happens, and the ability to learn things about people, do things if that's what they're for, etc. So um, getting the results then gives us a different view on things that actually has been informing our work at this stage. So um, here's just a quick look at our data. So in March, these were the types of samples that were presented to our 4 programs, and the numbers of those samples, number of each. So we had 10 fentanyl pills and 9 samples of powder, 5 of methamphetamine, heroin, Adderall. Uh, and this is what we found. Counterfeit pills of 10 of those pills that were expected to be fentanyl, only 4 of them actually contained fentanyl. But one of them also contained carfentanil. We found xylazine, heroin, acetylfentanyl is another analog of fentanyl. Um, uh, Acetaminophen and mannitol are there, in my opinion, because they have chemical properties similar to fentanyl. Primarily, they're melting and boiling points, because when people are smoking fentanyl, they're actually vaporizing it. And acetaminophen and mannitol will melt first, but fentanyl will boil first. And so they together, the mannitol helps prevent the whole thing from sticking to the foil. And then the acetaminophen kind of protects the fentanyl from burning, because burning fentanyl destroys it almost immediately. Which is, it's another something I'll touch on. In the powders, it was a little more. All 9 of those actually did contain fentanyl, but then we had all of these additional things. Cocaine, methamphetamine, and other things are commonly found in the fentanyl samples, but uh, at the top here, as they've said, in since 2022, and in 2.5, almost 3 years of doing drug checking here in New Mexico, we have found 0 samples of anything that wasn't supposed to be an opioid in the first place to be contaminated with fentanyl. So no fentanyl in the meth, no fentanyl in cocaine, no fentanyl in pills that weren't supposed to be fentanyl pills in the first place. Um, uh, Nothing on that, and I'll come back to that as well. On the other hand, all of this stuff is typically found in fentanyl samples, including the things I've mentioned. BTMPS is a chemical that's used in plastics and a few other things, and nobody is really sure why it's there, but there's some speculation that it can be deconstructed and used as a fentanyl precursor. So, um, so yeah, it's not at all true that there's fentanyl in everything, but it is definitely true that everything is in the fentanyl. So, and in New Mexico, the adulteration that we're seeing there, all of those things, is happening on the supply side, not on the retail side. We have almost 0 adulteration happening at the retail end. This was as it says, qualitative analysis of counterfeit pills that were seized at the U.S. ports of entry with Mexico. And they look exactly like the same things that we're finding here, which indicates that adulteration again, or to me, I think only part of it is intentional. I think part of it is the cooks not washing their dishes between the jobs that they're doing. We end up with all of that. A lot of the chemicals that you see on there are all related to fentanyl manufacturing, uh, precursors, intermediaries, and degradation products, they call them. Fentanyl is a very unstable chemical. It starts to fall apart pretty quickly after it's manufactured. Um, Again, all of our methamphetamine samples have just been methamphetamine, and our crack has all been crack. Cocaine, we've seen a few things, but they're only things that we are related to cocaine or known to be cocaine. Heroin has made a recent comeback, but it's about 50-50. Some of it is just heroin, and some of it is heroin and fentanyl, and some of it is fake black tar that just fentanyl and related products in it. So um, all of the Xanax, almost all of the Xanax that people have brought to get tested have been counterfeits, um, primarily containing an illicitly manufactured benzodiazepine called bromazolam. Um, Much stronger than alprazolam, behaves more like Valium. It's longer lasting, and that has shown up in our preliminary quite a bit in our preliminary mortality data this year. I don't have numbers for that yet, but yeah, it's going to be there. Um, the lorazepam and clonazepam combination are pill. We've seen a few of those. Those are pills that are bought at pharmacies just across the border, being sold as Xanax. Uh, so it's something like common that's happening as well. Do more case studies because we've had alerts that have gone out on increased overdoses recently, and this is what that looks like. I think I'm going to land this just in time. Um, the change that has occurred is previously we almost never were able to see fentanyl in our samples because of that detection limit, that 5%. But over the summer, we've seen the quantity of fentanyl in these samples jumping to above 5%, and we're able to see them pretty clearly. Uh, this one from Rio Arriba also contained medetomidine, although the person who gave the sample said there was nothing unusual about their sample. So don't know if it was there in a quantity that was enough to impact that person's experience. Nonetheless, I thought that was super interesting. There were overdoses here in the spring, and then we had some in Albuquerque that were connected to this very potent, what appeared to be heroin that turned up, and it also, though unfortunately, contained fentanyl, which has caused a bunch of associated with this. Um, there were a bunch of overdoses all in a 24-hour period here in Las Cruces in August, and this was a sample of some of the powders that was causing it. It was actually pretty poorly made fentanyl, but again, it was, according to the crime lab, that same product was very high, like maybe even over 10%. That did more in Albuquerque. This one happened to contain both xylazine and carfentanil. Uh, Currently, 83% of the fentanyl powder samples in Albuquerque are also contain xylazine. It's over 60% Rio Arriba. Then we had, there's been another situation unfolding in Roswell, or the southeast part of the state, where we're starting to see incredibly messy and potentially problematic substances. This one contains both medetomidine and xylazine and three different fentanyl analogs, plus BTMPS and some other leftovers, and very potentially problematic substances. And this was in a pill, even not a powder. So we've managed, in the short time this program has been around, has resulted in three health alerts going out to providers with information, and we've been able to marshal resources behind each one. Xylazine last spring, last fall we saw like very much market disruption in the fentanyl products, and an increase into those really messy combinations of things that I showed, but sometimes without any fentanyl at all in the pills. And so people were showing up at the OTPs and the emergency departments and other places asking for help because the drugs weren't getting them out of withdrawal. So getting this information out there helped our medical folks to understand what they were being told by folks that were asking for help. And then we just did this one based on the increase in fentanyl content and some of the overdoses that were happening. So, second to last one, we have also been contributing to research. So our samples were included. This study on the left, I'm a co-author on looking for the prevalence of fentanyl in stimulants, and our determination after looking at samples that were sent to our the UNC lab, was that after adjusting the confounders, there were about 9.1% of samples of stimulants that contained fentanyl. But we also thought that number was probably too high, because it seemed from the data that we got that most people already knew there was fentanyl in there, or it was expected. Um, and they chose to send these samples to a drug checking program. So more recent data has found that it's about 2% in the whole country, about 2% of non-fentanyl substances. So really uh, great to be able to push back on that myth and some of the stigma associated with those kinds of statements about the drug supply and people who use drugs. Our data contributed to the one on the upper left, looking at the spread of BTMPS around the country, and the one that the quote from the bottom was from yet another report that was published about the local anesthetics in the drug supply. So it really helped us contribute to a bigger picture of what's happening in the world. And as I talk about pushing back on stigma, you know, thing I've learned while I've been doing this work now is that pretty much none of us actually know very much about drugs. A lot of untrue information gets repeated as if it's fact. Um, and we end up with stories like this in the press that most people don't just blow off as being nonsense. We spend the rest of the day wondering if that stuff is true. Um, Most of what we're told is confusing and magical, contradictory. Uh, uh, I love this picture. Legalizing marijuana with a picture of somebody cooking dope in a spoon. Um, it is really infantilizing to not only people who use drugs, but to everyone, kind of prevents us from being able to talk about drugs like adults. And it vilifies people that are using using substances. Uh, you see ads like this. Our drug checking has found that no, you don't find common household things in drugs. Um, Another thing that most people just kind of accept as truth. Um, we find ourselves wondering if we can overdose from touching fentanyl because of all the crazy things we see on TV and in the news. We wonder if stories like the cannibal one is true. Um, Unfortunately, all of that stuff distracts us from the real harm that uh, our society's relationship with substances uh, has. And both of these are examples I took from real life. The one on the left was a screenshot from my phone from the news. Google sends me almost nothing but stuff about drugs because that's what I tend to do most of my research on. And the one on the right was from a newspaper that was folded up at my on my desk. Um, and I think that oftentimes people just don't even see these things when they're confronting us every day. Um, but I think that doing this kind of work is helping, giving us some leverage to try to attempt to bring some sense back to how we manage drugs. And uh, that's that. Sorry, I know I came right up to the minute, but uh, boom.
Thank you, Phil. Oh my gosh. What the amount of information and the checking program and everything that goes into it, the staff, the process, even down to like looking at the specifics into like what is exactly in some of these drugs. And so thank you. Thank you to the checking program at DOH and all the work that you do and everything that you've done to contribute to the program. So
Yep.
we'll pause
Our
here. Oh, go ahead.
our reports, and in fact, I can show real quick. Our reports and things are online. Let me share that screen again. And as well as all of the other materials that we've developed as a result. Share. And if you go to nmharmreduction.org and under resources, all the different types of materials we've developed to help folks both in English and Spanish, our FAQs about different substances, how our drug checking program works, how to use test strips, how to xylazine, what all these things are, and we have all those in English and Spanish available. And we have a separate tab up here for the adulterated checking program, and the reports that we published so far are in there. Soon, this is going to host a dashboard that'll be interactive and stuff, so people will be able to look at that and pull down reports for grants and things like that.
Perfect. No, that's perfect. And I put the link in the chat. I'm gonna see if health councils have any questions or comments at this time.
Wow. Eye opener. I I work with I he's presented for us in our opioid 360, and I just I, I'm in awe. Thank you, Phil.
I I know that's a ton of stuff, and I'm happy to come back and repeat stuff and do focus more on like the supply stuff itself and things like that if people are interested in that. So
They are interested, and you know who to talk to because she lives with you.
yeah. So yeah, I'd be happy to present to the Opioid 360 or any of the other specific councils. That was helpful.
Awesome. And I know a lot of health councils are doing Narcan, distribution and training and connecting people to resources, but to get this overview behind the scenes is also, yeah, really eye-opening to Gina's point. Any other questions or comments at this time? And if not, totally fine. Thank you so much, Phil. I know we're a little after 1, but we're gonna be sure to share the slides and the recording with other health councils who weren't able to make it today, and your contact information, just to ensure everyone has access and able to contact you if they have questions after.
Yep. Always happy to do that.
Thank you. Well, thank you so much, Phil, for your time and everything you've been able to contribute to the program in our state and all the amazing work that you do. So thank you, everyone. Happy holidays and have a good one and a good weekend. So we'll see you soon.
Yep.
Bye.